everyone, and welcome. My name is Katie Volk. I will be your facilitator for today's webcast, and I just wanted to let you know that we'll get started in about 2 minutes. While you're waiting, go ahead and answer the poll questions right below me, and we'll be back online to chat with you in about 2 minutes. All right, well, welcome everyone to the What is Trauma-Informed Care and Why Does It Matter webcast, sponsored by Great Lakes MHTTC and the New England MHTTC. My name is Katie Volk. I am one of the site directors for the New England MHTTC and also do quite a bit of work around trauma-informed care, particularly on the implementation side of things. I'm very excited to be with you here today. We are going to go ahead and get started with our webcast. If you haven't already, fill out the poll questions below. They're going to go away in a few minutes. And I can see people still queuing into the webcast and getting into the room, which is terrific. Excuse me. So the reason I ask these poll questions is just it helps me gauge examples. It helps me gauge background. It also lets you know who else is in the room. In a few minutes, we're going to put up a chat box where you can ask questions, and we'll certainly be, I view this as a little bit of a conversation in so much as we're able to have a conversation in this format. So I'm just going to take a look at these poll questions now. It looks like, and people are still queuing into the room, but it looks like we've got a lot of people from mental health clinics and community health centers, a few from public health and addictions and K through 12 education. People know a little bit about trauma-informed care. They feel confident. They know quite a bit. No experts in the room, at least not yet, but that's very helpful to know. And it looks like our group's a pretty even split across, or not quite, more people working with adults than are working with kids, some with youth, some with the elderly. A handful with people experiencing homelessness, a lot of people working with people with co-occurring disorders, that doesn't surprise me, and some other. And let me, I'm realizing I can broadcast these results so you all can see them as well. So let me go ahead and do that here. And we still have people coming into the room. So while you all are finishing filling out the poll questions, just by way of introduction in a little bit more depth, I'm going to describe the MHTTC network in a few minutes, but while we're all getting settled. So like I said, my name is Katie Volk. I live a little bit south of Boston. I work for a group called C4 Innovations. We are based in an office park in Needham, Massachusetts. We work around the country delivering training and technical assistance and doing research. My background is a lot in the homelessness and mental health field, and particularly in trauma-informed care. I'm trained as a child development specialist, and so that's the lens I bring to a lot of the work that we do. And I love working with organizations around the implementation side of trauma and trauma-informed care work. I think it makes just such a difference when you can dig into the kind of policies and procedures and into the service needs and how you're responding to people and how we're working with one another. I've seen it make such a difference for both staff as part of organizations, but also certainly for the people that organizations are serving. And so I look forward to chatting with you. This is one in a series of 3 webcasts. I'll talk a little bit more about that at the end. And so I think right now, it looks like most of the people are queuing into the room. I'm sure there'll be a few stragglers. But what I'm going to go ahead and do is kick us off, and the poll is going to go away, just so you know, last chance. And just do a little bit of housekeeping information. If you have called in either through the computer or through the phone, please either mute your speakers or mute your phones so there's not a lot of background noise. Know that this webcast is being recorded and will be available on our MHTTC websites on Friday, and we'll put the links up for that. The chat box below me is a great place to ask questions, comment, introduce yourself if you're so inclined. I try to keep an eye on the chat box while I'm talking, and we'll answer questions for sure at the end, but we'll try to keep an eye on it while I'm presenting as well. If you have any questions after the webinar, certainly feel free to email us at newengland@mhttcnetwork.org. I'll also put up our email and the Great Lakes email at the end of this webcast. You can also use the chat box for tech questions, and we have a tech person standing by. Her name is Vanessa, and so she'll be handling that piece of things. The last piece of housekeeping information I wanted to say is that we are offering continuing education credit for today's webcast. We are able to offer continuing ed or CEUs for addiction professionals, social workers, and through the National Board of Certified Counselors, a variety of counseling professions. So in the next few days, a link will go out to everybody who participates in the webcast. You'll have to answer, there's a knowledge check you have to do, so you have to answer a couple multiple choice questions accurately, and then fill out your information, and then we'll email you your CEU certificate. And this is good for 1 contact hour, this webcast. So if there's any questions about that, feel free to put them in the chat box, but that's all of our housekeeping information. So let me describe a little bit about the MHTTC network, and then we will dive into our main agenda for today. So we are a SAMHSA-funded network. It stands for Mental Health Technology Transfer Center, which is a fancy way of saying training and technical assistance for the mental health workforce. The country is divided up into 10 regions, as you can see here on your screen. This webcast is brought to you today by the New England MHTTC and the Great Lakes TTC. You can see in green and in orange there on your map. The TTCs were really organized by SAMHSA so that we can provide training, technical assistance, and also collaboration across our region. So we collaborate quite a bit with one another, but we also look at what's going on in our region, because maybe there's something in Maine that's happening that's really interesting that would be helpful for Connecticut to know, and providing those linkages, making sure we're not duplicating efforts. It's all part of the TTC mandate. So let's dive into our topic for today, which is trauma-informed care, what it is and why does it matter, and then a little bit about what do we do about it, which is really we'll touch on that today, and then discuss that more in depth in the coming webcasts. So, and you'll have to forgive me, I have a little bit of a cold. I like to situate this conversation by just stepping back and recognizing that traumatic events, although they occur quite a bit, we consider them extraordinary because they overwhelm the ordinary human adaptations to life. This comes from a book called Trauma and Recovery, written by Judith Herman quite some years ago. If you haven't picked it up, it's a fantastic resource. Our bodies and minds are profoundly equipped to cope with stress. Traumatic stress overwhelms those adaptations, and that is why we call it trauma, because it overwhelms the systems that we have. And so whenever we're working with someone, I think that's a really helpful frame of mind to have as we're thinking about healing and recovery. So what is trauma-informed care? There are a lot of definitions out there. So I've been doing trauma-informed care work for about 15 years now. And I'll say about 15 years ago, nobody had really heard about trauma-informed care. The pendulum, I think, is swinging on that a little bit. It's the word is out. SAMHSA talks quite a bit around trauma-informed care, so do other federal and private funding sources, and that's always a good sign that things are getting into the kind of vernacular of a profession. Trauma-informed care also, though, becomes then a buzzword and gets thrown around quite a bit without really understanding the depth of what it encompasses. And so there are many definitions of trauma-informed care. I'm going to offer you a few today, and I'll tell you why I chose these couple. One is understanding, anticipating, and responding to the issues, expectations, and special needs that each person may have. At minimum, trauma-informed services should endeavor to do no harm. What I like about this definition is that last piece. We should endeavor to do no harm. When you are thinking about working with someone one-on-one, when you're thinking about policies and procedures, thinking about how to work with one another as a team or on a staff, because of course trauma-informed care applies to all of us. It's not just for patients or just for clients. It's for everyone. How can I, in those scenarios, when I'm making those decisions, how can I endeavor to do no harm? How can I ensure that I'm not re-traumatizing someone? That really, for me, becomes a touch point, and it's what I like about this particular definition. SAMHSA also has a definition that I find very helpful. Trauma-informed organizations, programs, and services are based on an understanding of the vulnerabilities or triggers that trauma survivors have that traditional service delivery approaches may exacerbate, so that these services and programs can be more supportive and avoid re-traumatization. So trauma-informed programs look at everything through the lens of trauma. They understand what the particular needs of trauma survivors are, what goes on in the brain and the body, what goes on in the healing process, and looks at all of that and then adapts their services, their programs, their policies, their interactions accordingly to be trauma responsive, trauma informed. So why does this matter? It's all well and good to talk about trauma informed care in the abstract and make sure you know, all right, trauma, stress response, all of that. But why does it matter? And I think it's important for us to understand this coverage and to be able to explain it to others who maybe don't know much about trauma-informed care or who are maybe looking to fund best practices in the fields of mental health and homelessness and other kinds of service provision scenarios. So the first reason is that trauma is a universal experience. It used to be thought that only 2 groups of people experienced traumatic stress. If you have any guesses, go ahead and write them in the chat box. This is, I guess, going back about 40, 50 years ago, we thought the trauma field only thought there were 2 groups that experienced traumatic stress. Go ahead and take a stab and see what you think. Yep, veterans, combat veterans was one group, correct? And what about the other group? There's one more group. I see a bunch of responses coming here. Victims. So I can see all kinds of attendees responding. So yeah, so the first group was combat veterans, the second was sexual assault survivors. What we now know, though, is that we all experience trauma at some point in our lives, most likely. The most common is the sudden unexpected loss of a loved one, but certainly and particularly I think for the populations we work with, trauma is ubiquitous. It's everywhere. And excuse me, to situate this, the study of trauma has a really interesting history. It sort of ebbs and flows based on I think what the current climate is, what the research is producing, where we are in terms of what's going on in the world. Sometimes it's front and center, and sometimes people are just kind of blocked off to it. It tends to be that when there is an uptick in war and violence in the society, people are more aware of it, and then during times of peace it sort of fades to the back. Trauma survivors know that it's ever present. What is tricky then is that when we deny that trauma is going on, it allows ourselves to distance ourselves from action. And then what ends up happening is that the services focus on the individual rather than on the culture and in the environment. And we need to focus on all three, right? Certainly individual services for trauma survivors is critically important to healing and recovery and is a lot of the work that all of us are doing. However, the culture, the environment, the systems is a really key piece of that. that healing and that structural response. And so that's why we're focusing on implementation of trauma-informed services so much over the next few webcasts. Along those lines, I want to make sure that we talk about the adverse childhood experiences study. So a number of years ago, a group of researchers had access to the health records of de-identified health records of people enrolled in Kaiser Permanente, so a health insurance HMO in the Midwest. And they collected a whole range of data around stressful or traumatic experiences in childhood that included abuse and neglect, witnessing domestic violence, substance use, mental illness, parental discord, crime. It was 10 things that impacted well-being and health across the lifespan. The population that they studied, was about 17,000 people, looked at the population that they studied were mostly middle class, well-educated, primarily white. And what they discovered is that about 2/3 of the people in the study had experienced at least one ACE, which was really surprising to the researchers at the time. Because, again, the field had assumed that there were only those two groups or a handful of groups that had experienced domestic violence. And what the ACE study, and since there's been many replications of this, what the ACE study has helped to teach us is just how embedded trauma is in our society, and also that it relates to premature death in adulthood, decrease in resiliency many times, heart disease, increased risk of suicide. So they were able to link the adverse childhood experiences with a whole host of other both risk factors but also physical health impacts. And it was really the first time in a large-scale way that this was documented. If you haven't heard of the ACE study and would like more resources around it, put it in the chat box and I'll make sure I put some websites in there at the end of the webcast. So one of the reasons we study trauma-informed care and talk about trauma-informed care is because it's everywhere. Another reason is that it has a far-reaching impact. And for those of us who have experienced trauma, or if you're working with people who've experienced trauma, you know that trauma doesn't impact just one slice of someone's life. It impacts us in a really far-reaching and often profound kind of way. From a physiological point of view, it impacts our brain architecture and function. It impacts your frontal lobe, your prefrontal cortex, and your stress response, which is the back of your spine here. Stress hormones can get elevated. You have increased sensitivity to what we call triggers, so people react very quickly, and often unconsciously out of the place of being triggered by their past traumatic experiences. And it also has significant mental, physical, and behavioral health implications. And so, like I said, we're not just talking about one slice of our lives. We're talking about a really far-reaching kind of impact. This quote, I think, captures the more psychological or spiritual impact of trauma. Trauma destroys the fabric of time. In normal time, you move from one moment to the next. After trauma, you may move around in circles or bounce like a rubber ball from now to then and back again. Anyone who's experienced trauma or who is working with trauma survivors knows that sometimes you lose time or lose track of time, and it feels like you're back in that scenario and now you're here all over the place, which can be incredibly disorienting, along with the physical health impacts that trauma has. And so I'm curious, because I know you all have quite a bit of experience working with people, I'm curious, what have you noticed? How have you noticed that trauma impacts people? You can go ahead and type it in the chat box there. So Nathan is saying a lot of difficulty with trust and relationships, for sure. I do a lot of work in the homelessness arena, and I say, like, if you've never had a good trusting relationship, it actually is incredibly reasonable that when we come along, kind of well-meaning social work types, people would look at us and say, unconsciously, why would I trust you? Nobody has ever been trustworthy, so I'm just going to assume that you're out to take advantage of me. I can see intrusive thoughts, self-medicating, a ton of health problems for sure, anger, nightmares, so incredibly hypervigilant. So a lot of those hallmarks of PTSD, post-traumatic stress disorder, certainly increased substance abuse and relapse. There's a lot around power and control that goes on, and when we talk about trauma-informed care and do no harm, we talk a lot about power and control. How can you minimize power hierarchies, for sure. Physical problems, just general instability, a numbness, certainly. So you all know this in a deep kind of way. And so the challenge, I think, or the opportunity is to really take everything that you're writing in the chat box here, and I can still see responses queuing, so keep at it, is to take all of those things and then to design a system and services and procedures for people who have all of these various challenges. And there is a real opportunity there to create wonderful and responsive services and systems. And I've seen programs do remarkable things when they embark on a process of becoming more and more trauma-informed. So as I've mentioned, the other reason to focus on trauma-informed care is that trauma does not just affect individuals. It affects our organizations, it affects our systems, and it affects our communities. This is not an individual, just an individual issue. It's also not just an individual issue in terms of impacting just patients and clients. It impacts us. Many people in the human services field have experienced trauma themselves. And so when we're talking about trauma-informed care, we want to think about the organization. We also want to think about the team. We want to think about protecting and healing ourselves as well, and still being professional and still having good organizational culture and policy, et cetera. So let's talk about prevalence across systems, because many of you, I know most of you are in the mental health field. We touch a lot of different kinds of systems, no matter where we're working, right? So I was doing homelessness work, I was talking with child welfare, and I was talking with housing, and I was talking with healthcare, and certainly mental health. So in healthcare and primary care settings, it's hard to get exact numbers, but there is a high rate of people who have been exposed to traumatic events. Many people in primary care often have a diagnosis of PTSD. You can see wide variabilities in those numbers because it's very hard to narrow it down and get good data collected in that way, although I do think that's changing. In the mental and behavioral health field, 93% of psychiatrically hospitalized adolescents have a history of physical and or sexual and emotional trauma. 75% of clients in substance use treatment report histories of significant trauma, often from childhood. I would guess that these numbers aren't surprising to you, but when I see percentages like 93 and 75, what I think we can all assume is that when we are working in the mental health field, you assume that anybody who walks through your door has experienced some kind of trauma. And unless you're doing one-on-one work, in some ways it doesn't matter what that trauma is, so long as you have a responsive service system. And I'm talking big picture. Of course, when you're getting into individual work, it does matter. But from a systems point of view, you want to make sure that it's like a universal precaution. One of the popular questions that I get asked when I'm working with organizations is, well, Kate, so what I really need to know is, who do I do the trauma-informed care to? I just want to say, we don't do trauma-informed care to anybody. It's not something like that. We set up, it's a universal approach. It's a milieu kind of way of working to create a service system that is responsive to everyone, no matter what they've experienced. Just for a few more, to look at a few more prevalence statistics in the criminal justice system, and I think maybe a few people may work in the criminal justice system here or certainly have had connections to it. 96% of female offenders have experienced trauma, often in the form of sexual abuse and intimate partner violence. These are hard statistics to say out loud. 75 to 93% of youth with juvenile justice experience have also experienced trauma. In some ways not surprising, and in other ways really staggering. In the child welfare system, and now I always take a little bit of issue. I think if you're in the child welfare system, you've experienced some kind of trauma. I would say it's 100%. But what the research says is that 50% of youth in the child welfare system have experienced trauma. In the education system, 1 out of every 4 kids in school has been exposed to a traumatic event. And important to note is that people living in poverty have higher rates of trauma exposure and PTSD than other socioeconomic groups. And when you layer on top of poverty, race matters. We live in a racist society. Certainly, if you read the headlines, you all know that. And the racial component to this is deeply interwoven in everything that we've just talked about in terms of prevalence. And so that's just another layer of analysis, another layer of something we want to pay attention to, and certainly from an equity perspective, something to consider. So actually, before I go here, I just want to pause here. If there are any questions, go ahead and feel free. I know the chat box has kind of been humming down here. If you have any questions at this point, certainly go ahead and type them in, and I'll take a minute to look at them. And while you do that, I'm going to take a sip of water over here. All right. So what do we do about all of this, right? So we know the why and we know the what, and what do we do about this? I like to think of trauma-informed work as the entire conversation, and this is a concept called trauma stewardship. It comes from a wonderful book called Trauma Stewardship, written by Laura Vandernoot-Lipsky, who is has done quite a bit of direct service and is now a speaker and a trainer based in Seattle. She would tell people, if you're going to pick up one book on trauma, this is a really good one on trauma-informed care. She talks about trauma stewardship as the entire conversation about how we come to do this work, how we're affected by it, and how we make sense of and learn from our experiences. And I think that this is personal work. I have yet to meet someone who comes into the human service field just because, or if they do come into it just because it was a good job to take, they stay for very personal, very mission-driven reasons. So when we think about trauma-informed work, it's deeply reflective, because we want to understand how we come to this work, how it affects us, in terms of the kind of the positives, because for sure I can't imagine, and I'm sure this is true for many of you, I can't imagine my kind of professional and personal life course, if you will, without having done so much of this work. It's impacted me in so many deep ways. That also, the flip side of that coin is that we're affected by it deeply in terms of vicarious trauma or burnout. It's personal work, and so it affects us in ways that are challenging. And then the last piece is how we make sense of and learn from our experiences, because we've got to be able to do that reflective work on ourselves in order to be able to think about trauma-informed services and systems. Because ultimately, when we start thinking about trauma-informed care, we are not just looking at, as I said, the individual. We're looking at changing the practices, the policies, and the culture of entire organization. We're increasing staff knowledge and awareness, increasing skills of trauma, and creating an environment that is sensitive to the needs of survivors. And last but not least, why trauma-informed care? Along the lines of this being really mission-driven work, we're called to alleviate suffering. That is a personal ethic of mine. I think it's a personal ethic of many people who are in the human services field, that fundamentally we know that people who are in the mental health world or in substance use or in child welfare or wherever you enter the conversation, people are suffering. And if we have the ability and tools and best practices to be able to alleviate that suffering, we're called to do that. And trauma-informed care is an approach that helps everyone. It helps organizations, but it also helps helps us as we try to go forward and build something that really works for people. What I want to do now is just pause and see if you all have any questions. I'm curious to know where you are in the implementation process. Is it something you've thought about, something that you are currently actively trying to implement? It sounded like for a few of you, you know a bit about trauma-informed care. So I'm going to give you all a minute to just type in the chat box what your experience with trauma-informed care has been so far. And while you do that, I want to give just a few examples of how I've seen organizations implement trauma-informed care and what brings them to that point. So worked with a housing program in the Midwest who was very interested in implementing trauma-informed care because what they were finding, just kind of organically, and this was many years ago, what they were finding is that so many of the women who were coming into their programs not only had a housing issue, so were experiencing homelessness, but also had so much trauma behind that. And so they thought, all right, well, we've heard of trauma-informed care. We really should get to know a little bit. They got to know a little bit. They got to know a little bit more. And then what that ended up looking like was taking their policies and procedures around how they ran the housing complex that they were managing and really taking a good, hard look at how they could take what they knew about trauma and really implement it in their housing complex. And so it was very hard for them because they had one model of doing things for a long time. And so one of the first steps in that process was to really make sure the staff understood and have staff buy-in. So we did quite a bit of training with them to raise staff awareness to make sure people understood this is a trigger, this is what triggers look like. When people get triggered, they have fight, flight, freeze responses. Here's what it looks like when you've experienced complex trauma, so trauma from childhood and over time repeatedly, and worked with staff a lot around that piece. And then meanwhile, opened up their policy book and said, well, this is how we've been doing things for so long, but we've got to start taking a good inventory of what this can look like. And so they did, and what they figured out was when they looked at their room check policy, for example, so they did a room check every night. There was a curfew and, you know, like things you had to check off in terms of making sure the rooms were kept a certain way. It was so transformational because when they put on their trauma lenses, their trauma glasses, the executive director used to say, and really thought about the procedures that they were going through from a survivor's point of view. What would happen is that the house manager would go through and you get, they work with families, so they would get a smiley face or a frown face for their curfew and their chores, etc. And if you got a certain number of frown faces, there were consequences to that. And when they looked at that from a trauma survivor point of view, they realized that it felt really judgmental and shaming for the staff and for the participants that were living there. And so that was hard because they'd been doing it for a long time that way. What they ended up doing was taking a step back, pulling in some people who had graduated from their program and said, all right, this is how we've been doing the room checks. We've got to do them. Like, there are certain things we just can't budge on. We need people to be doing chores and taking care of the house and all these kind of things. What do we do? And it was the hard part for them was actually the conversation around, like, recognizing what we are doing is not working for trauma survivors. Once their advisory board of people with lived experience took a look at that, they said, well, the form that you're using, so that the house manager would go around with the form on a clipboard. Once they took a look at that, they said, oh, well, you can just change around the wording a little bit. So the changes to the form itself hardly any time at all. What the long-term work of raising staff awareness, getting staff buy-in, and then ultimately coming to a decision to make a change, that was the hard part. And once they did that, they then had a more trauma-informed way of working with people. And so I'm seeing someone here in the chat box say, people don't share during so doing initial trauma screenings is helpful. They think trauma happened so long ago they're not affected. Yeah, I'm glad you brought that up, Adrienne. The process of screening, so there's a couple things. One is, I think, my computer just froze. Okay. One is, I think some programs are reluctant to ask about trauma from the get-go, which, given that you don't want to open up a wound, right, for people that you can't then close or have the ability to kind of encapsulate or hurt, or you don't want to do any harm for people. So what we typically recommend is to make sure that the organization is functioning in a trauma-informed way, and I'll give an example in a second, so that you are assuming when people walk through your doors that they do have a trauma history, and that everything from the way that they're greeted at reception, to the environment in the waiting room, to the way that the direct care staff is working with people, to the clinical staff, all the way through the spectrum, the continuum of care that people are receiving in your setup, is trauma-informed. And like I said, I'll give an example in a second. The other piece is that screening, we should screen people for trauma, but it should not be done right away necessarily, depending on your program setup. It's hard to speak in generalities on these webcasts because you never know. I don't know the individual nuances of each program. But you do want to have it as part of the conversation, so you lay groundwork, and it's never going to be a one-time screening, right? You don't want to screen people and then never bring it up again. But there are ways to do it and ways to work with your team members who are doing those intakes to make sure that you're doing it in a sensitive kind of way. And sometimes that means writing a script and practicing it and role-playing it. You certainly don't want to just dive right in to the trauma, right, before you ask about other less sensitive things. You want a little bit of rapport building. I know some programs that when they do their screening and assessment or screening and intake, will say, they'll go through a whole battery of pretty innocuous kind of questions, and then towards the end, when they feel like they've got some rapport, say, many people who come to our program have experienced violence or have experienced trauma, so I'm going to ask you a few questions about that. You're welcome not to answer that. If it makes you uncomfortable, we can stop at any time. I'm just going to go through these couple of things, and then they have a short standard protocol that they go to, and that seems to be a good way to set it up. Even if the person says, no, I'm not interested, you've planted the seed that many people in the program have experienced trauma, and then that's something that this organization is open to talking about. So it's not happening behind closed doors. It's not the elephant in the room, so to speak. And I can see Tina asking a question here. Is there I don't know, HT, I'm not sure what that stands for. Is there a trauma screening other than the ACEs screen? Certainly, and so the ACE screen is 10 questions. There's a website called ACEs Too High. You can get more information there. There are certainly other screeners, and that maybe we can put together a list and share that. Some organizations come up with their own set of questions based on the work that they're doing. I don't want to give any specific recommendations here without knowing kind of the context of people's programs. There are ways to screen, if you're working with kids, there are ways to talk with parents about the trauma histories of their children, so you get a little bit of that kind of information. There's screeners pediatricians use. There are screeners that have a few questions about trauma embedded here and there, kind of single questions that primary care providers use, for example, around intimate partner violence, or do you feel safe in the home? And that's just one question that's tagged on to the end of things. So there's a number of ways to do it there. I'm just going to make a note. So along the lines of the screening process and thinking about the environment, there's a community health center that we've worked with that I've worked with over a number of years that works with clients who, many of whom have mental health challenges, many of whom have substance use, many of whom have homelessness or other kind of housing instability in their world. They work with a wide range of ages. Like I said, they're a community health center. And what they were finding is that their staff, once people started talking about trauma, their staff was actually pretty well versed in having those conversations. Many of them had clinical training or other kinds of backgrounds that enabled them to do that. But there was a lag. And so when they started looking at trauma-informed processes, one of the things that they prioritized was they realized, as a community health center, people's first introduction to them was through their waiting room. And so they made it a priority to redo their waiting room in a way that brought in a lot of natural light so people didn't feel boxed in, because that certainly can be a big trigger for people if they start to feel claustrophobic, if they have their back to the door. So they reoriented the furniture. They opened up a few things so they had more light in their waiting room. What they realized is they wanted to be sure to protect patient confidentiality when they came up to the window to check in for their appointment, which could have been things that were very sensitive in nature, could also have been things that were fairly routine. I have a sore throat, can you check it out, that kind of thing. So their first endeavor into that was to put one of those little clinical noise machines right by each of the front desk stations. And what they realized is that they had so many people coming in with untreated psychiatric challenges that they would look at the little boxes, noise machines that kind of emitted that noise, and think like, are they recording me? What's going on? And it actually inhibited the trust that that people coming in from the community had in coming up to their front desk. So they got rid of those. They got a little boom box. This was a couple of years ago. They got a little boom box, and they played very, very, very mellow classical music. They put it on a table, kind of off to the side, right by their front windows, really, really gentle, so as not to be triggering, and loud enough that you couldn't hear the conversations happening at the front window. So that does a couple of things. One, it's a very calming environment to come into. So when you come into a community health center, you also may be struggling with a variety of things. So it's a very calming, not stressful experience to sit in their waiting room because you've got natural light, you've got this nice music playing in the background. It also protects privacy and confidentiality in a very clear way when you come up to that front window to say, I'm here for an appointment for an HIV screening, I'm here for following up on my diabetes, I'm here for whatever it is. And so it sends a message to people right when they walk in the door that this is a place that is trauma-informed. This is a place where we have thought about how our patients go through every step of the way. That helps alleviate suffering. It helps with all of the different dynamics we've been talking about today. It's a clear example. They also, I should say, the other thing they did is they put artwork from many of their patients up on the walls. They had a community art program, and so when you walked in, it was just felt so client-centered, so patient-centered, so person-centered, because you had this beautiful artwork and then, like I said, natural light. And it didn't cost them that much. That's the other, I think, misconception is that, I've been in public health waiting rooms in the basements of churches and all kinds of other places where the space is not ideal, right? Most of us are not working in spaces that are ideally equipped for the kinds of things we might want to have, but there are really inexpensive ways to make sure that your environment is trauma-informed. So it's just about 1/4 right now. I want to make sure to leave time for any questions you might have, any challenges you might be facing. So I could talk and give examples all day. I wanted to give a few so that you had a little bit of a sense of some examples, but I'm going to pause now for questions, and I'm going to go ahead and just read the chat box real quick. Yeah, so Tina, there are screenings that are a tool healthcare providers can use to determine underlying causes of health issues, for sure. There's a wonderful talk on ACEs by Nadine Burke-Harris, and actually I might be able to put the link in the chat box here. Let me see if I can do that for you. She is a pediatrician working in California, and she talks about how primary care, and she's a pediatrician, so it comes from that perspective, but she talks, it's her TED Talk, Tina, that's the one I'm thinking of. But she talks about, like, if you know that ACEs, if people have high ACEs, it leaves them at higher risk of diabetes than the rest of the population. You want to make sure that you're more aggressive with treating any precursors to diabetes as a healthcare professional. She ties it together really, really well. It's something that I show in all of my longer trainings because I think it's just a useful, she ties it together in a really useful kind of way. And I'm just going to see if I can pop the link into the chat box here while we're talking. So hopefully this won't start to play on my computer when I pull it up so I can grab it for you all. All right, so that's Nadine Burke-Harris. So let's see, I'm seeing another question. Can you share language to use in an intake form that will capture all sexual orientations and gender? Certainly, I'm glad that you brought that up because language makes a huge difference. And even doing that, you know, in terms of coming up with very specific ways to start becoming more trauma-informed, one thing some organizations do is say, all right, there's a laundry list of 15 things we want to do. We're going to start by reading for gender-inclusive language. We're just going to read everything and make sure the language is gender inclusive. That is a trauma-informed way of proceeding. So there are starting to become, along those lines, Donna, there are starting to become more standardized ways of asking about gender identity than there used to be. And it's usually from a healthcare perspective, there are some best practices on there. What we have done on some of the screening tools we've done, you know, and this is particularly working with kids in a healthcare setting, is ask about gender assigned at birth, gender identity, and then preferred pronouns. And so even just to start there as part of the conversation is helpful. If you are wanting to know about sexual orientation, if that plays a role in whatever kind of healthcare you're providing, there are also kind of becoming more standardized ways to ask those kinds of questions with different kinds of options. If you shoot me an email afterwards, I'll send you some of those resources, at least that we've got at our fingertips. And I'm just making a note here. I can see somebody else typing. And that's another way that that we become responsive to the population that we're working with. When I walk in here, I can recognize that this is the place that I belong. My preferred pronouns are. Just doing those kinds of things from a cultural responsiveness and sensitivity point of view sends a message that this is a place that takes me and who I am into account. So certainly would be a trauma-informed way of proceeding. And a lot of times when people look at their policies and procedures, and in future webcasts we have actually a standard way of going through and evaluating policies and procedures, but when we go through those, looking at the tone and looking at the language you use plays such a huge role, right, in reducing stigma, making people feel more welcome, making people feel not judged but included, and those things play a huge role in trauma-informed care for sure. You can see a bunch of people typing here. I'm going to pause and take a little sip of water. Yeah, so Donna's question around there. So there are future webcasts. Let me pull them up here. That's our contact information. I'll put that up. So the MHTTCs offer a whole range of webcasts. For trauma-informed care, we are offering 3 webcasts that are open to everyone. The next one will be trauma-informed care in the context of a recovery-oriented approach, which will be facilitated by me and Rebecca Miller from Yale University. We'll do another one after that on the nitty-gritty of implementing trauma-informed care. So I've touched on it a little bit here, and that one will get into the more specifics. And then from there, we're actually going to be taking applications, and since you all are in attendance today, you'll be on the list to get this information. We're actually forming a learning collaborative of organizations that are ready to start thinking about implementing trauma-informed care. And through that learning collaborative, you'll work both in large groups and small groups in a format similar to this, but both in large webcast presentations like we're doing, and then in smaller groups where you're actually able to be off of mute and have a conversation, to really think through all the nitty-gritty of implementing trauma-informed care in your specific setting, and you'll be able to get more tailored consultation. So today I'm sort of speaking in general and giving kind of broad examples, but in that case we'll have facilitators who can really work with you in more detail. So first step, if you're interested, would be to register for these other 2 webcasts, and then just know that you'll get the Learning Collaborative application if you're interested in applying. And I'm seeing here another question, so just give me a chance to read it. What are some subtle ways to approach sexual trauma with adults and children that are not to upset them or make them relive the trauma? Angela, I'm guessing that you're thinking about more of a screening and not trauma-specific therapies. Trauma survivors know that they are trauma survivors, whether we ask or not, and we do people a disservice by not asking. I've heard from many medical professionals over the years who say they don't ask women about intimate partner violence when they come into their care because they wouldn't know what to do about it. To which I would say ethically, find something to do about it, right? Let's educate ourselves and find something to do about it, because that may be the only setting that a woman is there by herself and can disclose that she's in an abusive situation. So that's to say that in terms of subtleties, you want universal screening, I think, is a good way to do it. You don't want to be singling people out who you think may have experienced sexual trauma. With children, I would be much more careful, and that I would want to have a separate conversation about, because with kids, there's a lot of nuance to having those conversations that because of their status developmentally and things like that, that you really want to take into account, and that's far beyond kind of the depth and scope and even ethics of this webcast. I wouldn't want to say anything off the cuff. But with adults, I think a universal screening approach is okay. Not to ask for details, but just yes or no kind of screeners. There are ways to do that I think is appropriate. So Tina is asking, is there a conversation around implementing trauma-informed care at a state policy level? The short answer to that is yes. The longer answer is it depends which state you're in. So varying states have varying levels of conversation. I know Massachusetts has done things in the school system. Wisconsin, Ohio, Washington State have all had varying initiatives around trauma and trauma-informed care. Other states have had small slices of things being implemented. I do think at a state policy level, those conversations are really, really helpful. Because ultimately, when you become trauma-informed, you want the individuals, I think of this as a bullseye, you want individuals in your program to be working in a trauma-informed way. You want your team to be working trauma-informed. You want your organization, and then the wider system also needs to be trauma-informed, so that it's kind of a universal approach. So yes, Vanessa answered the question. This webcast is being recorded. There will be a transcript of Liz, I'm not sure if you need a transcript, like a written transcript. We do closed caption all our webcasts. The closed captioning won't be available by Friday, but it will be available sort of down the line. I don't know what the turnaround time on that is for something like this at this point. But we do record all of this, and we'll put everything up on our website. I think I missed a question in here somewhere. And maybe I didn't. All right, so if you have a question that I didn't answer, or if you have another question as you're thinking about this, certainly go ahead and type it in the chat box. I'm going to do a few more things before we wrap up here. So, as I said, this webcast was put together by the Great Lakes MHTTC and the New England MHTTC. My name is Katie Volk. You can have all of our email addresses are there if you have any questions at all. You know, around this, we're all working really closely together, and so if you kind of email one of us, you sort of get all of us because we're in such close communication. If implementing trauma-informed care is something that is of interest to you, I encourage you to think about applying for the Learning Collaborative. It's a really good process. It's one we've done with organizations before. You emerge from it with a strategic plan for how to work in a trauma-informed kind of way. If you're curious, I recommend attending the other webcasts that we're going to be offering, and I'll put those back up here. The registration links are right there, because that'll give you even more of a sense of some depth around trauma-informed care. The goal of today was really just to provide an overview and a kind of the why of trauma-informed care. So in terms of wrapping up here, and we'll wrap up in about 5 minutes. What I'll say is that you will receive on Friday, you are gonna receive an email with a link to an evaluation. That's very important. That helps us in terms of our communication with funders and in terms of knowing what's working well and what did not work well about the webcast, because we do these all the time, and so we rely on good feedback to make sure we improve them. Within that email will also be, if you're interested in continuing education credit for this webcast, you'll fill out something there. There's a little knowledge check and send us your information, then you get a certificate via email. And this will all be archived on our website. So there's about 2 minutes before the end of the bottom of the hour, I guess. I will hang out here. If you have any questions at all, type them in the chat box or any comments. This is something, we are really committed to working with you all around knowing what trauma-informed care is, making sure it's getting implemented in good ways. I've made a couple of notes of some of the questions people are asking, because we're always looking for ways to develop useful tools for people. And thank you very much for your good participation. Like I said, I'm gonna hang out for a little bit, but this concludes the formal presentation part of our webcast today. So Nathan, I'm reading your comment here. Yeah, the secondary traumatic stress piece is a huge piece of, I think, thinking through what a trauma-informed response looks like. There's good research to suggest that even by acknowledging that this work can lead to vicarious trauma, that rates of vicarious trauma actually go down. Just by acknowledging that it's a thing that exists and this work impacts us. It's something we spend a lot of time working with organizations on. And the other piece I saw you mention is supervision, which is critically important and often one of the hardest things for organizations to implement in a consistent way. So Tina, I'm seeing, yeah, the statewide policy piece, for sure. Tina, if you are still on the line, tell me what state you're in. I'm curious, because it's so state by state and department by department specific. Washington State. Okay, good. Shoot me an email. There's a bunch of good stuff happening in Washington State around trauma-informed care right now. So Nadia, I see your question about the third part of the series being more supervision-based and prevention of secondary traumatic stress. The third webcast is really going to focus on implementing trauma-informed care and what steps we encourage organizations to go through when they're doing that. However, I am confident that at some point in the next 6 months or so, we will end up doing something on secondary traumatic stress because it comes up so much. Supervision is not something we've tackled quite yet, although we do offer quite a bit around that. So I'm going to write that down and take back to the team because when we're wearing other funding hats, we do quite a bit around supervision. Nadia, yeah, assessment, contextualization, and like sort of, okay, so now we know all this stuff about trauma-informed care, we're on board. Now what do we do? What happens first, second, third? How do we make sure it's sustainable? How do we assess and benchmark and put things into place? It really sets the stage for the Learning Collaborative, that third webcast. And Nathan, you're asking, do you have a list of approved or recommended literature or workbooks for treating trauma? On the treatment side, there are a handful of things probably I could recommend. I don't have it. We tend to focus more, we, and I mean me, on the implementation side, so trauma-informed implementation, more like programs and systems and policies. I always hesitate to recommend treatment protocols kind of off the cuff without knowing more about your program. In terms of trauma-informed care, there are a number of things that I recommend, many of the ones that I cited in the presentation today, and we'll cite in kind of coming webcasts. I'm making a note here, though. All right, well, this concludes our webcast. Thank you so much for coming. We are going to stop recording and close this out, and the archive will be ready and posted on our websites and sent out to you all on Friday. Thanks very much.